how should clinicians adjust LDN dosing for women across different phases of the menstrual cycle to account for fluctuating mu and kappa receptor expression?
So I think at first is really just education about hormones. It's super interesting to see. I can't speak to if you're European or Canadian or any other countries, but we do a really poor job at educating, in health in America. And we are, it's so funny. There's like this American squeamishness about all of that stuff. And that I find that's not among Europeans. Even just me personally talking about this, I can do this with my patients, but with my daughter. It's so uniquely American, I think. But the first thing is education. Educating our patients and really getting them to understand their hormones. I literally draw it out with every woman talking about this, even if they're in menopause. So women are told when they're in menopause that they don't have hormones anymore. I said, are you kidding me? We have ovarian senescence. It's not dead, I mean, it's that we get our hormones elsewhere. We have our adrenals making hormones. We have all of our tissues, and other endocrine organs, We first need to educate. And so when I start naltrexone, especially if it's a adolescent or it's a woman who's perimenopausal, for instance, I will just have that acknowledgement to say, I really want to understand, where you're at. And if a woman has, for instance, PMDD, which is a more severe premenstrual disorder, which encompasses mood and chronic pain changes, or she has endometriosis or adenomyosis, I will talk about the fact that she may have a different response. Some patients may need to titrate their LDN dose, but in practice, I have not found that. I have found patients that tolerate LDN in their luteal phase versus follicular phase will tolerate it. I have not had to stress dose or reduce during that time, but it's just something to note. So for instance, my patients with endometriosis, a lot of them, there's a very, very significant inflammatory component. I have some of these patients that require higher doses. I want to reference Dr. Paul Anderson. I think all of us do a wonderful job here of talking about the clinicians that have inspired us. Dr. Paul Anderson at the previous conference, I always fangirl him. I think he's amazing. He's done this a lot longer than I have. Sorry, Paul, to say that, but you have, and he's taught me a lot. And one thing that he coined is the term high low dose naltrexone. So I have a lot of patients who either were gastric bypass patients, they don't do Roux-en-Y gastric bypasses anymore because it's so detrimental to health, causes chronic overgrowths and problems, so I'm having to manage that, but they have chronic malabsorption and terrible malabsorption, and so they need higher doses. We have patients like that, or we have patients who, as Paul said, we want to give, if you go higher than 4.5, so if we're in the 6 to 12 milligram space, we're primarily doing more anti-inflammatory response versus max immune system modulation. We really think for up to maybe 4.5 milligrams. Maybe that's wrong, but that's kind of our understanding right now. And so that's why we try to hit that sweet spot right around 4.5 or 6 milligrams, because we're trying to double dip. We're trying to get anti-inflammatory response and immune modulation response. So I talk, my endometriosis patients, a lot of them are requiring higher doses or twice daily doses because there's just such an inflammatory component. The other really amazing thing that we've known since the work that was done at Creighton in the 1960s is women with endometriosis have very severely low endorphin levels, and that impacts their fertility as well. So we reduce that inflammation, we improve the endorphins, they can get pregnant. It's amazing. But I think it's that education and figuring out what each woman needs.